You'll love me for saying this, Tubo-Ovarian Cancer. So it is really his bugbear that the ovarian cancer is actually starting in the fallopian tube. So that's why I kind of refer to it as the Tubo-Ovarian. So just to give an overview, I'll give a very brief overview. I think Ian covered a good bit on the ovarian cancer, Tubo-Ovarian cancer there. Talk about some of the new research developments in the area which have helped kind of pave the way for discovering hopefully new tests, and then talk about what a liquid biopsy is, and explain why this has been kind of a revelation over the last few decades in developing new tests for screening and diagnosis. And then I'll give a brief overview of the research that's being done in Queen's and the Belfast Trust as well. So as Ian says, ovarian cancer, it isn't a common cancer, but it does affect about 150 women in Northern Ireland each year. And as he mentioned as well, if you have a BRCA mutation, you're at higher risk of developing it. Unfortunately, the majority of women are diagnosed at a late stage, so over 75% are diagnosed when the ovarian cancer has already spread from where it started to other parts of the body, and that really limits the treatment options that we can give and reduces the cure rates as well. And the reason for this is that a lot of women don't experience any symptoms until the disease has spread. As Ian also mentioned, there is no screening test. So the blood test, the CA125 test, which is a protein that is released by ovarian cancer cells, but it's also released by inflammatory cells and things as well. So it's, as studies have shown, those long-term follow-up studies have shown, it's just ineffective as a screening tool. We can use it to monitor response to treatment, but it's not used in the definitive diagnosis or screening of ovarian cancer. So we really, at the moment, have no effective method of screening, and this is an area of unmet need. The reason for that being that there's CA125 doesn't work, there's a lack of symptoms, and I can't remember what the third thing was in my thing, but there is an unmet clinical need. Yes, our current detection methods are just poor. So there are a number of recent developments that have helped pave the way to identifying new potential biomarkers or tests that we can pick up on tubo-ovarian cancer. As Ian has mentioned, there is now overwhelming evidence that the most common type of ovarian cancer, so the high-grade serous, which is the most aggressive as well, starts at, not in the ovary, but if you click as well, there's another, but starts in the fallopian tube. And as Ian pointed out as well, this is a progression from where the normal cells go through stages, develop into what they call a pre-cancerous lesion, this serous tubal intraepithelial carcinoma or stick lesion, which then becomes a cancer, which can stick to the ovary or spread to other parts of the body. And what we want to do is try and detect the ovarian cancer when it's at these earlier stages. So that's one of the key developments. The second key development is the types of biomarkers that we look for. So we have genetic and epigenetic biomarkers. Genetic biomarkers are things like mutations. So the BRCA mutation is something that can be detected. And if you have a mutation, it can change the DNA sequence within a cell, which then changes how the cell acts. And in the case of cancer, that means it can multiply or grow out of control. And that's what the mutations do. So picking up on those mutations then can be a way to detect for cancer. Epigenetic changes are different, so they don't change the sequence of the DNA, but they're little molecules that attach to the DNA itself, and it can change the structure of it, but it has the same consequence as having a mutation in that it can change the way the cell behaves and encourage them to grow out of control and become cancerous. And these epigenetic changes, the most common one is a thing known as DNA methylation. So it's a wee methylation marker that sticks to the certain parts of the DNA, changing its structure. And these changes happen at a very early stage, even before mutations in some cancers. So this is why we're really interested in being able to detect these methylation changes. And it has become a major approach in biomarker development in recent years. And the third thing is the liquid biopsy. So what I mean by liquid biopsy, it's something that will give you the same information that you can get from, say, a tissue biopsy, but from a bodily fluid. So blood being the most common one, but any bodily fluid. So you can get it from urine, from saliva, from cervical mucus and things like that as well. And there's lots of different components floating through the circulation or in these fluids, but the most commonly and the most extensively researched one is the cell-free DNA or circulating DNA. And what that is, you have fragments of DNA that are released by healthy cells, but they're also released by tumour cells, and tumour cells can release a lot more, and they're slightly different from the healthy DNA as well. And when the term we use when we're talking about circulating DNA in the blood is the circulating tumour DNA. So what we want to do is be able to, what research is doing is finding out what the normal circulating DNA is like, the characteristics of that, then comparing that to the cancerous and finding out are there changes that we can distinguish those two types of DNA. And there's lots of different ways in doing that. But it has a big potential for use as screening tests. So I'll just explain kind of the advantages of liquid biopsies over the standard traditional tissue biopsies. So if you're cutting out a piece of tissue, so if you're having a biopsy or surgery for a cancer, it cuts just a certain part. But as you can see from the diagram, the cells in the cancer can be different in different parts of the cancer. So you might only be getting the information on this one particular part, so you're not getting the whole information that describes exactly how the cancer is growing. So it's not uniform. It generally involves surgery or a biopsy, which is invasive. This generally involves overnight stays in hospitals or a lot of experienced clinicians or other healthcare professionals to carry out the biopsies. And actually processing this information can take a bit of time as well, as there's a number of steps between getting the tissue and being able to actually figure out what the DNA shows. So compared to liquid biopsies, as you can see, the liquid biopsy, it's a simple blood test. I know some people might not like needles, but it is a lot less invasive than having a biopsy or a surgical procedure. And as you can see, all of these different types of cells can be picked up in the blood sample. So you're getting a more comprehensive overview of what is actually going on within the cancer. Blood tests are generally safe, they're not expensive, you can get the results really quickly, and they can be repeated multiple times as well, which is really important because it means that you can follow somebody throughout their cancer journey as well to see how the cancer is maybe changing. So there's, as I said before, I carried out my PhD with Professor Mullen in Queen's University, and we were looking at trying to identify and develop DNA methylation markers to detect Tubo-Ovarian Cancer. So first of all, we had to identify the DNA methylation changes that we felt could be detected in earlier cancer. So we were, we had, well, myself and Dr James Burton, who had carried out the preliminary work for this in his PhD, had collected samples from patients who had normal fallopian tube tissue, the stick lesions, and then had developed high-grade serous Tubo-Ovarian Cancer as well. So we compared all of those tissues looked at the DNA methylation and tried to pick out markers that were present in the stick and the cancer, but not in the normal tissue. And it was those markers that we then took forward to try and develop a blood test. So we, during my PhD, we collected tissue samples and matched blood samples from patients with high-grade serous tubo-ovarian cancer. We carried out the analysis to look for DNA methylation, and from what you can see here, we were looking for markers that were switched on or off. So the red markers are on, the blue markers are off. This is kind of the, I think here is the high-grade patients, and you can see in their normal fallopian tube they're off. They start to get a bit more red, and then they're red in the cancer. So it was this group that we took forward here of markers, and that was actually thousands of markers to take forward. So we then still need to pick out, it's not possible to kind of analyse all of those, so, and we wanted to pick the ones that were specific for the ovarian cancer. So there's lots of other researchers who have looked at these markers in normal healthy blood or in other benign conditions like inflammatory pelvic disease, endometriosis. So we're able to analyse the markers that were up in our cancer with publicly available information and pick out the ones that were just specific for ovarian cancer. Because when you're looking at the blood as well, you don't want these markers to be elevated in the blood normally. You want to pick markers that are going to be specifically just up in the ovarian cancer. So that took a bit of time. When we finally did get rested on the markers that were specifically for ovarian cancer, then that's the ones that we started to take forward to develop into a blood test. There's been a few other developments which have helped along the way. So as you can imagine, with the amount of components that are in the blood, picking up on a very small fragment of abnormal DNA, you need extremely sensitive technology. So in previous years that was just impossible, but there have been advances in technology like this droplet digital PCR, which can really pick up on minute changes or minute concentrations of these DNA fragments, and that's what we use to develop our test. As I said, you can detect very small amounts of DNA. Somebody describes this as trying to find that circulating tumour DNA as trying to find a needle in a haystack when the haystack's made of needles. So it is fairly difficult thing to do. And the other thing that we liked about the droplet digital is that you can actually test multiple markers. So if you think back to the different coloured cells that you had in your cancer, not everybody is going to have one methylation marker up. There's going to be kind of a variety of ones. So we want to get a panel of a number of different ones that will cover kind of the variety that we see in the population. So far we've developed and identified and developed over 100 markers, and we're now working to optimise those into one single test that will be able to detect the ovarian cancer at its earliest stage. So I'm just going to show you an example of kind of the three, some of the earlier three that we took through. So this is the normal fallopian tube, so the normal cells, and this is the high-grade serous, so this is our cancer cells. And as you can see from these three markers, that the DNA methylation was up in these three markers in the cancer cells. When we combine those together, we get an even more sensitive test, and you can see that there's a clear separation here, and that's what we're really working on now, on those 100 or so and more markers. We're trying to get the best combination that we can find, and the droplet digital technology, I think it limited to about 4 markers, but there are technologies now where you can actually add a lot more, up to about 15. So it's constantly developing, and that's really encouraging. The other thing that we did is we broke down our markers into what stage the woman's cancer was at. So as you can see, this is like stage 1, which is the earliest stage. we didn't have a lot of patients on stage 4, but you can see the markers are up in that early stage, so that's really encouraging as well. And we're still in development, but we have started to test our markers on blood. Blood samples are really precious, and you want to make sure everything is kind of perfect and optimised before you test on that, because you only really get one go at it. So we've been able to test a combination of markers, and you can see there that in blood where our markers are distinguishing between the normal and the cancer. So what we want to do is to do this in kind of a larger number of samples once we've kind of got really nailed down the markers that we want to put on our test. So just in summary, there is a definite need for earlier detection of ovarian cancer, and this will improve kind of the overall survival for anyone diagnosed with it. We've no effective screening methods at this point in time, and we really need to change that. There have been a few things in recent years that have made this a potential possibility, and we've identified a number of markers from the novel approach that we are taking that will hopefully be able to detect early stage ovarian cancer. We're developing these in blood, and it's looking possible. And as I said, there's constantly advances and evolving changes within this area, so it is making it hopefully a realistic possibility. We're not there yet, but hopefully we will be. Thank you for listening.
Thank you, Laura. Laura did very kindly offer to take any questions that were directed to Ian as well, if anyone wanted to do that. Well, obviously as well Wendy could answer about the protector study. If anyone did have any questions for Laura about Ian's talk or obviously her own research.
Sorry, can I ask? Sure. You mentioned something about the prolonged use of HRT in the connection of breast cancer, but I thought, I understood it to have dropped significantly, because initially I had not thought on HRT because of the higher risk of breast cancer.
I think our next speaker is actually a Q&A on HRT, so they're way more experienced than me, if you don't mind if we put that question in.
Yeah, I don't know a lot about ovarian cancer, so is there any kind of signs that you may feel or look out that could be a sign that, is there any type of...
So the general signs would be kind of bloating, constipation, things around the tummy area, and that's because when you are getting symptoms, it's because it's generally in the more advanced stages. General things, they're quite vague, which is the issue. Weight loss, tiredness. A lot of women are going to their doctors with possible irritable bowel syndrome, and because there's no kind of real screening test, then it's maybe kind of thought to be something else for a while. So that's one of the why they call it the silent killer, really, because the symptoms can be so vague, and when they do come, it's generally when it's at the more advanced stages.
Is it useful to do the liquid biopsy or not to discover the early stem cells of ovarian cancer, and where we can do or make the liquid biopsy?
Are you asking where you can do a liquid biopsy?
Yes.
So there are some cancers where it's used as standard already. I think one of the first liquid biopsies was in lung cancer. And in colorectal cancer it's used as standard as well. So these types of tests are coming into kind of standard diagnostic practice. They're just not in ovarian cancer, but they are tests that are used as standard in some cancers.
And we should ask an oncologist or the gynecologist?
So generally, if you're diagnosed with the type of cancer where liquid biopsies are used, these tests will be offered to you. It's a blood test, and generally it's taken at the same time as you're getting routine bloods. I know for the Belfast Trust, our samples, a lot of the liquid biopsy samples are run at Queen's. They have a diagnostic centre right beside the hospital, so you can get the results very, very quickly. For some others, they have to maybe be transported over to England, but generally they can be processed quite quickly.
So at the moment, there isn't a test being offered for ovarian cancer, a liquid biopsy, but it's in development. But I think what I was going to is that as researchers, we cannot do our research. Laura wouldn't have been able to do the research without the donation of tissue, of blood from people like yourselves, family members. We, again in Northern Ireland, we're very lucky. We have a Northern Ireland Biobank who will help researchers to access those tissues. If you are interested in donating tissue, donating blood, as researchers we would love that. I would say there's a caveat at the moment, is that we are not able to collect it outside routine clinical practice at the moment. So you would need to be attending clinic anyway for either surgery, or sometimes it can be follow-ups. But please do ask clinicians and say, ask questions. I also earlier just mentioned there's also other ways to get involved in research if you are interested. Within Queen's there's a PPI, a public, can't remember what all the P's stand for, but availability for you guys to be able to help influence research questions and take part in research if you are interested. I'll flash up the slide later. And also, as Ruth mentioned, there's always other ways of contributing as well to research, even into service provisions and clinical trials. So definitely please do take part if you are willing and able. As researchers, we can't do it without you.
I normally have a thank you slide, but
the
main thank you is for patients as well, because literally none of this would happen without that.
So we are actively recruiting samples at the moment within breast and ovarian and pancreatic and lung. So we are actively recruiting.